Good morning, good evening, wherever you are. Welcome to another emergency questions and answers for families in intensive care and intensive care at home. We're getting so many questions from families in intensive care and intensive care at home that I thought I'll get on another one and answer your questions live on the show. My name is Patrick Hutzel. I'm the founder and managing director of intensivecarehotline.com. I'm also a critical care nurse consultant for families in intensive care, as well as I'm the managing director of intensive care at home, where we send critical care nurses into the home predominantly for long-term ventilated adults and children with tracheostomies. I have been working in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years. We've been consulting and advocating for families in intensive care all over the world since 2013, and we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. If you click on the testimonial section there, or if you go to intensivecarehotline.com and you have a look at our podcast section where we've done client interviews. With intensive care at home, we have been sending critical care nurses into the home for long-term ventilated adults and children with tracheostomies in Australia since 2012, 2013. We are employing hundreds of years of critical care nursing experience in the community, and we have saved many lives with our service and keeping many patients at home with our intensive care at home nursing service instead of them staying in intensive care. Now, let's look at some questions in a minute. Also with intensive care at home, like I said, we're currently operating all around Australia in all major capital cities, in all regional and rural areas. We are NDIS approved, and we're also TAC WorkSafe in Victoria, iCare in New South Wales, and NIISQ in Queensland. Now, let's look at some of the questions that have come in during the week so that you can get your questions answered. And if you have any questions in the meantime, type them into the chat pad, or simply join me live on the show here. And you can do so by clicking on the StreamYard link here. You can use that link, or you can type your questions into the chat pad, but the quickest way to answer your questions is simply by clicking on the link and talk to me directly here. Now, first question comes from Grace, who says, "Hi Patrick, the ICU team wants to take my daughter off life support tomorrow. What should I do?" And this is a very generic question, and for some of you, this might be a slap in your face. You might think, what's going on there? But unfortunately, this is the reality in many ICUs all over the world. And it is also what I've witnessed in ICUs. Like I said, I've worked in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in ICU before I started with intensive care at home and intensive care hotline. But the reality is that, many ICUs want to take people off life support, often without family consent, often without asking a patient, and sometimes you can't ask a patient, but then you need to look at consent from families. And what if there isn't consent? Then you need to look at laws, legislation, guidelines. But end of life care, taking someone off life support does not happen in a vacuum, right? Intensive care teams pretend that they can do whatever they like until you challenge them. We have saved many lives in situations like that, where we advocate for our families, and where we also make sure we hold intensive care teams accountable by reminding them, well, you can't just take a patient off life support without getting consent from a patient or from a family in that situation, right? So what should you be doing? Well, first off, you should be advocating for your daughter, and you should be clarifying whether there's an advanced care directive or not. So what I mean by that is, if there's an advanced care directive where your daughter has documented clearly that if she's ever in a situation like that, that she wants to have all life-saving measures to be done, then the intensive care team needs to honor that. That's one step to how to deal with it. The other step to take is, if ICU teams want to take patients off life support without patient or family consent, there is a hospital policy, right, around that procedure, whether an ICU team can just take a patient off life support without patient or family consent. Because if they do that and there isn't consent, that could be perceived as murder, could be perceived as euthanasia, depending on the exact situation, right? Whether someone, is getting sedatives or opiates to make them quote unquote comfortable, because that's often the euphemism that intensive care teams use, saying, oh, we just give, maybe morphine, midazolam / Versed to make your loved one comfortable. It depends on the amounts that are being given. Is it hastening death? If it is hastening death, would that be perceived as euthanasia? And euthanasia is still illegal in most cases. So those are questions that you need to ask. And I can understand from a family perspective, you would be so shocked by thinking that this is even an option for them, that you reach out and you don't even know what you should be asking. Because another question that needs to be asked here is, have they exhausted all treatment options? Just because they want to take your daughter off life support, what does that mean? Is it a real or a perceived end of life situation? So I've been talking about this for over a decade now, that there's a difference between a real and a perceived end of life situation in intensive care. So, for example, a real end of life situation, that means that nothing, no surgery, no medications, no fancy equipment can save a patient's life, right? So you're at the end of the road. A perceived end of life situation means that, ICU teams want to take someone off life support, but don't offer any alternative treatment, or they don't want to keep going, even though they haven't exhausted all options, and it's just a perception that, a patient will die, right? And if they do take someone off life support, they will die, right? But if they keep going and continue treatment and, look at other options as well, then it's a perceived end of life situation from my perspective. And you need to ask the question, is it real or perceived, right? What is your perception? Is the ICU team just trying to create a narrative of, it's quote unquote in the best interest for your daughter to die? Again, that's just a perception. Is the conversation around quality of life or perceived quality of life, like, are they saying, well, we should take your daughter off life support because if she does survive, she won't have any quality of life? Well, what is quality of life? What is it? It's a perception, right? What might be a quality of life that's acceptable for me might not be acceptable for you, and vice versa. And it should not be up to intensive care teams to determine what is quality of life in their eyes. It's up to you and your family. And one thing is for sure, if your daughter is being taken off life support tomorrow and she dies, well, there's no return from that as far as we know, right? But you know that if you keep going, there's hope. That's for sure. So it is really important that you're not intimidated in those situations, that you do know that you have rights. A lot of families are so taken aback by those situations, they don't even know they have rights. They believe everything that they're being told. Oh, we'll just take your daughter off life support tomorrow at 3:00. And that's like an execution. That's shocking. And you need to stand up for your rights. And many families have taken hospitals to court, and and then It's a matter for the courts to decide what's going to happen next. And keep in mind, hospitals don't want to deal with courts because it drags their name out into the open. The media might get wind of it, and they certainly don't want to be in the media to talk about, that the hospital is taking patients off life support against patient or family consent. That wouldn't be a good headline. So you have to think along those lines. Where is your power, right? Da Vinci, you're saying, what should you do if your rights are being clearly violated or delayed? Yeah, good question. So the first thing that we always advise is to get access to the medical records. That's the first thing, right? The next thing that we strongly recommend is that, I talk to doctors and nurses directly on behalf of our clients. So if your rights are violated, let me ask some questions, or we can set you up with questions to ask, because a lot of families in intensive care, they simply don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So, by a clinician asking, hey, what is really going on here, you need to get the full picture. When someone is critically ill in intensive care, there are dozens and sometimes hundreds of things happening simultaneously. And unless you've worked in the environment for decades like I have, you really don't know what you're looking for. It's like piecing together a very complex jigsaw puzzle, right? Can you give more insights on why your rights have been violated? Can you be more specific, Da Vinci? You can also join me live on the show here and talk to me directly by using the StreamYard link that I just posted in the chat pad. You don't have to go on camera if you're camera shy, but you can talk to me, and I think your questions will be answered so much quicker, right? If you can give more information why your rights have been violated or delayed, that would be really good, and I'm sure I can help you and break it down for you. Another thing that we do for our clients is we write to hospital executive, often with much success. From my, again, extensive experience, hospital executive cannot ignore the complaint of a patient, right, or a family. Patients often can't speak for themselves, but especially when they're in ICU or in critical care. However, they can't really ignore the complaint of a family, and a lot of it also depends what rights have been violated. Is it the right to a second opinion? Is it a right to discharge your loved one to another hospital? What rights are you talking about? What rights is it that you are referring to? So I hope that helps, Da Vinci, but please keep your questions coming here for anyone on the call. Keep the questions coming, and in the meantime, I will just read out, go to the next question, but in the meantime, type your questions into the chat pad or join me live on the stream here. There's a StreamYard link that I posted in there, and you can join me live on the show and talk to me directly here, and that's the quickest way I can help you on this emergency meeting. It is an emergency meeting because I know many of you have loved ones in critical care and you need help now. In the meantime, I'm moving on to the next question that's coming during the week from Evelyn, who says, thank you so much, Patrick, for your informative videos. My brother is in a similar situation in ICU. The doctor didn't ask us about DNR, but instead told us she would not resuscitate him. Da Vinci keeps going here and says, basic stuff: a right to dignity, privacy, and humane care, a right to be free from harm, including unnecessary or excessive physical restraint, isolation, medication abuse, or neglect. Yeah. That sounds full on. And a lot of hospitals with staff shortages and You know, it feels like it's inhumane care and there's no privacy and no dignity. Thoughts on DNR? Don't sign it. Don't agree to it. Full stop. Don't sign it ever, unless it is your loved one's wishes. There are people out there who don't want to be resuscitated, and that needs to be respected too. However, if your loved one is critically ill in intensive care now and can't make decisions for themselves, and you are the power of attorney or next of kin, and they're asking you, would you sign a DNR? Stay clear of it. Do not sign a DNR, and here is why. The minute you sign a DNR, you're basically allowing them to wind everything down. And that is what often happens when DNRs are being signed. You know, it's sort of when doctors and nurses hand over to each other, they say, oh yeah, this patient is DNR. And that's sort of the sign for them, oh yeah, we're not even going at half steam now because the patient's DNR anyway, right? I would never sign a DNR unless your loved one has indicated to you that's what they want. Either needs to be respected, but it doesn't sound to me like that's where you're going with this, that you want to sign a DNR for your loved one. You know, because the next thing then is, once a DNR has been signed, okay, I'll give you a very tangible example here. Let's just say you've signed a DNR and your loved one goes into kidney failure and all of a sudden needs dialysis, right? They will say, oh, he's DNR, we're not going to do dialysis. That's often what you get. Whereas if a patient isn't DNR, the conversation will be started differently. Yeah, you know, this patient is for full treatment. Of course, we're doing dialysis. Right? That is just one example of many examples. You know, same could happen if your loved one goes into cardiac failure, into heart failure, and they're saying, oh no, we're not going to treat heart failure because he's DNR anyway, he or she is DNR anyway. Right? You're almost setting up this cascade of withdrawal of treatment when you sign a DNR. So you're saying some medical staff accused of placing DNRs on patients without family knowledge? Absolutely. Absolutely. So I can give you, once again, some tangible examples here out of my, decades worth of ICU experience. So when I worked in ICU, I have witnessed it myself and I have always challenged it. Right. And it wasn't well received, but I didn't care, right? Because I am a patient advocate. I do believe the nurses are the real patient advocates regardless. So I have seen it in practice when I was still working in ICU, but I've also seen it here with intensive care hotline where, when we look through medical records, we find that DNRs have been signed by hospitals, not by families, and that is illegal. We have been involved in some court cases and where hospitals have signed DNRs without family consent or without family knowledge, and they've always been revoked, as part of our evidence as well. So it is common practice, absolutely. Unfortunately, it is common practice. And that's why you can't start doing your own research early enough when you have a loved one in intensive care. You just simply can't. It's a once-in-a-lifetime situation that you can't afford to get wrong. You can't afford to get that wrong. Or for organ transplant donors. What I will say is this about organ transplant. So let's just say someone is, when treatment is withdrawn, one of the next questions that always comes up is, would your loved one want to donate organs, right? Or when patients are being declared brain dead, the first question that comes up, okay, can we harvest organs? It is a very, it's a very delicate and sensitive topic. Is treatment being withdrawn because someone is waiting for organ donation? Is that a question that needs to be asked? I think it is a question that needs to be asked, right? I don't have enough insights in how the organ transplant system works. I know there's a long list of people waiting for organs. There's no question about that. Is treatment withdrawn prematurely because, maybe a VIP is waiting for an organ donation? I don't know. I don't have any insights there. Have I seen? What I will say is this: I do believe that treatment is being withdrawn too early in ICU. That's what I do think, right? And is that with the agenda of harvesting organs? I don't know. Could it be? It could be, but whether it is or it isn't, I don't know. But the question needs to be asked. That is for sure. I hope that answers your question there, Davingsi, in terms of, is a DNR placed to let a patient die and then harvest organs? It's a valid question that I don't have the answer to, but it is absolutely a valid question. Okay, so once again, type your questions into the chat pad or join me live on the show here and ask your questions here. If you can use the StreamYard link that I'm just posting into the chat pad. In the meantime, I have another question from Evelyn who says, "Hi Patrick, thanks for your information with your videos. My brother is in a similar situation. The doctors didn't ask us about DNR, but instead told us they would not resuscitate him. He has had an MRI and it was fine. I'm disgusted by the response of the doctors saying she would not resuscitate. As you have informed me now, it is not their choice. Would you remove him from this hospital? Thank you. I'm in Australia." Okay, Evelyn. The first thing that I would do before you move him to another hospital is simply asking them to remove and revoke the DNR. That's what I would do. Right. I wouldn't be moving him to another hospital straight away. Here is a problem in Australia in particular. If you move him to another hospital within the same sort of city or area, there's a high chance you might come across the same doctors again, because doctors often work in more than one hospital. I would, in a situation like that, Evelyn, I would focus my efforts to getting the DNR removed. That's what I would focus my efforts on, 100%. And most of the time we will be successful with those efforts, right? This ties right in with the question that we had a minute ago here from Davingsi. Never ever agree to a DNR, because if you do, you're more or less giving permission to slowly but surely withdraw treatment, which is often what they want. So they can create their narrative of, well, I told you so, your loved one is not going to survive, your loved one is not going to make it. Once again, what's the worst case scenario for an intensive care team? Worst case scenario for an intensive care team is to look after a patient with an uncertain outcome indefinitely. That is their worst case scenario. You have to approach everything from that angle. You've got to decipher every communication that's coming from an intensive care team from that angle. What is their worst case scenario? And as long as you keep that in mind, that is really important. Okay, so now let's move on to the next question. But in the meantime, type your questions into the chat pad or join me live on the show here and talk to me directly. But my final thoughts on DNR is never ever agree to it unless your loved one wants a DNR. Like I said, that needs to be respected too. Very important. It's all about patients and families. It's not about you or about me. It's really all about what families and patients want. Okay, next question from Heather, who says, "Hi Patrick, my brother had a heart attack and is now in ICU. He has a severe anoxic brain injury and is on life support. They are pressuring us to make some decisions, but I feel like I don't understand the implications." Yeah, exactly. That's exactly right. You probably don't understand the implications because it's very early days. You haven't given us a timeline, but it sounds to me like it's very early days. even a few weeks in ICU may not be a long time, right? He might have a severe anoxic brain injury. And what are the decisions they want you to make? Have you had a second opinion? Have you looked at medical records, right? What are they basing you needing to make decisions on? So the biggest challenge, once again, for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So what you need to do in a situation like that is, number one, get access to the medical records, get help from a professional that's not affiliated with the hospital, which is what we do here at intensivecarehotline.com. We decipher clinical information for you, and we give you that second opinion. We also talk to doctors and nurses directly, and we ask all the questions that you haven't even considered asking. If your brother is in ICU with an anoxic brain injury, there's probably dozens, if not hundreds, of other things happening simultaneously. We need to look at, blood results, medications he's on, what's happened to this point from day one, who is involved in his care, what does the neurologist say, what has led to the anoxic brain injury, right? Was it a cardiac arrest that's led to the anoxic brain injury, right? And are there people that have recovered with an anoxic brain injury? If they have recovered, to what extent? Have they recovered to a full extent? Have they recovered to a partial extent? What does their quality of life look like? Is it a quality of life that would be acceptable for you and your family? Does he need a tracheostomy as a next step to give him time? Right? So also, most of the families that we work with, they're talking about pressure from hospitals. Okay, well, that's perceived pressure. You have a choice to respond to pressure or not to respond to pressure. You can't control other people, but you're 100% in control how you respond, right? You are 100% in control how you respond. And if you respond with panic, or if you respond with clarity, you are in control of that. Responding with clarity means you ask questions, right? And you ask the right questions, right? So that's all up to you. So I can see that MCR wants to join me here, but for whatever reason, I can't admit you here. I'm not sure why that is. Can't let you in for whatever reason. I won't be able to let you in for whatever reason. Try again. Try again. Lock yourself off and try again. In the meantime, so let's carry on with that other question. So I can't admit you for whatever reason. Let's try again. I'll take you out there and let's try again, please. I'll take you off and now try again, please. All right. So again, your brother might need a tracheostomy. And one implication of a tracheostomy would be that he has more time. He can't be staying on a breathing tube and a ventilator forever, right? But a tracheostomy will give him all the time in the world. The implications of you letting your brother pass away, the implications of that. There's no return from that. And then you will be scratching your head and potentially living with the guilt that you did approve your brother letting your brother go without exhausting all options, right? It's a critical decision to be made, and it's not a decision you should make lightly, quickly. You need to take your time. So MCR, I can see you trying to come on, but I can't admit you. I don't know what it is. In the meantime, keep typing your questions into the chat pad, or if anyone wants to join me here live on the show, please do that and wants to talk to me directly. Okay, in the meantime, I go to the next question from James, who says, I wish I had known, hi Patrick, I wish I had known about intensive care hotline last year. My mom's doctor forced the PEG tube off on her and no one would work with her to try to get her to be able to swallow again. She got aspiration pneumonia and the hospital wouldn't even try to help her. They forced the breathing tube down her throat and just let her get worse, eventually sending her to an LTAC where she got 5 stage 4 bed sores and sepsis. She passed away on May 26th last year. I've tried filing a lawsuit against the place she passed away in, but no law firm will take the case. They say her bed sores were inevitable. I am disabled myself. I live on a fixed income, and I don't think that the place should just get away with the neglect they did for my mother. Thank you, James, for sharing that. And I agree with you that no one should get away with any negligence in any case, right? Because if your mum more or less got killed and got forced the PEG tube, right, that's simply not good enough. Now, the issue there is, and I've been making videos about this, that when patients end up with a PEG tube in ICU, no one will ever bother trying to feed them again, right? That is my biggest concern that I have with a PEG tube, right? That no one will bother feeding your loved one ever again, right? They just think, oh, it's a PEG tube, it's permanent, let's not worry about feeding them ever again. Whereas a nasogastric tube is temporary, and that means people will make efforts to start feeding someone again, right? And you can wean someone off nasogastric tubes, whereas a PEG tube has the perception in healthcare that it's permanent, and people have the perception, oh, if someone has a PEG tube, no one, oh, we will never feed this person again because they've got a permanent placement of a PEG tube. And it's just not the right approach as far as I'm concerned, right? They're often done out of convenience without having real good intentions to wean someone off feeds, right? But by the same token, you are saying my mom's doctor forced the PEG tube. No one can force you. So I assume your mom could not make her own decisions, right? No one can force you to give consent to a PEG tube. No one, right? So, families also need to take responsibility for what they give consent to, and they also need to take responsibility for their own actions. And, maybe you haven't done your research at that stage, but that's why I keep saying it's so important that you are doing your research. It's so important that you are taking full responsibility, because if you're not taking full responsibility, to a degree, it is your own fault. And I know that sounds harsh what I'm saying now, but, the system is what you see is not what you get, right? So you will unfortunately need to do your own research, and you will need to make the right decisions, You're also saying your mom got aspiration pneumonia and the hospital wouldn't even try to help her. They forced a breathing tube down her throat and just let her get worse, eventually sending her to an LTAC, where she got 5 stage 4 bed sores and sepsis. Well, the bed sores probably caused sepsis. They say her bed sores were inevitable. I disagree there. I strongly disagree there. In ICU or in LTAC, every immobile patient needs to be having pressure area care every couple of hours, right? Patients need to be taken off the pressure of their skin every couple of hours. If the LTAC or the ICU can't provide that, they are negligent. As far as no law firm wanting to take the case, I can't comment on that. It might depend on how busy they are. It might depend on the age of your mum, because I do know, one thing that I do know is from some lawyers, they don't want to take cases of elderly patients because, and this sounds very harsh what I'm saying now, but this is what some lawyers have told me, that the older a patient, even though there might have been negligence, there's no money to be made. And that sounds horrible, but that is what some lawyers are telling me, saying, if you have negligence for a 25-year-old patient, there's money to be made. If you have negligence for an 85-year-old patient, there's no money to be made. It's horrible, but that's just what some lawyers have told me. But bed sores and sepsis are definitely preventable, right? That is, you know, the first thing that you learn in nursing school is how to prevent pressure sores, right? And if a nurse can't prevent pressure sores, they shouldn't be in the profession. You know, that is a number one duty of a nurse. You know, one of the main duties of a nurse is to prevent pressure sores. And like I said, no one should get away with the neglect for anyone in hospitals or in ICU. So thank you, James, for sharing that with our audience here, of course. Then and in the meantime, either type your questions into the chat pad or join me live on the show here by using the StreamYard link for our emergency questions and answers today. I also want to welcome everyone that's watching this on replay. And if you're watching this on replay and you have any questions, just type them into the chat pad and I will make a video about it. Right? You can also, if you want to, if you like the work that we are doing, you can make a small donation with the super chat button, or, you know, you can do that. The more content we can make for families in intensive care, the more people we can help. You can also click the like button, share the video, and subscribe to my YouTube channel if you like the videos that I'm making. Now, next question from Vicky. Vicky says, hi, Patrick. My husband received several sedatives and is not waking up after 2 weeks of those sedatives. That is definitely a concern, Vicky. And if your mum hasn't, if your husband is not waking up, clearly there's a big challenge. Now, in a situation like that, the first question is, what are those sedatives? Has he been on propofol, which is short-acting, or has he been on midazolam or Versed, which is long-acting? Has he been on Precedex, which is also short-acting? What has your husband been on, right? And for example, if he's been on midazolam or Versed for long periods of times, right, and he has been on high doses of it, he might simply not wake up because it's stored in the tissue, for example, right? Or if your husband is having issues with kidney failure or liver failure, right, the sedatives might not be metabolized or not excreted through the kidneys. Also, has he been on opiates such as morphine, fentanyl, hydromorph, oxycodone, because that also causes delay in waking up, right? Now, also, have they done a CT scan of the brain, MRI scan of the brain, and EEG of the brain to rule out a neurological event such as stroke, seizures, brain bleed, etc.? Right? Next, are they starting to mobilize him? Are they getting him out of bed? Right? You know, also, is he going through withdrawal? For example, if someone is on midazolam, which is a benzodiazepine for long periods of times, or in the US, midazolam is used as Versed, or the brand name in the US is Versed, right? It's a benzodiazepine and therefore it's causing addiction, right? Is he potentially going through withdrawal? What does not waking up mean, right? Does it mean he's not waking up at all, or does it mean he's slowly waking up but he's confused, he's agitated, what does it look like in reality? Can you, it would be good if you could have described it. Another thing that I need to explain here is when someone is coming out of an induced coma, or in this situation, not coming out of an induced coma, so, does your husband have a brain injury? Did he have a brain injury right from the start, for example? Was he in a car accident? Did he have a traumatic brain injury? Did he fall off a roof? Who knows? You haven't said that. Sometimes patients do not wake up after an induced coma, even though they don't have a brain injury, and they just need to rest and heal. And then sometimes patients are not waking up after an induced coma and they have a brain injury, right? So it really comes down to what is exactly happening. It comes down to what sedatives have been used, what opiates have been used, what quantities have been used, right? So sometimes patients need a lot of sedatives and a lot of opiates. And sometimes they're also on paralytic agents. So they are being paralyzed chemically with medications because they're fighting against the ventilator sometimes, right? So then you need to use strong sedatives, strong opiates, and paralytics, and that will further delay waking up. That's what I'm saying. When someone is critically ill in intensive care, you need to dissect everything in much detail before you can come to conclusions. And you shouldn't jump to conclusions either, right? Never jump to conclusions, because once again, the biggest challenge for families in intensive care is that they don't know what they don't know. When we look at medical records or we talk to doctors and nurses directly, we look at all facets, we look at all the details, and the devil is in the detail when you have a loved one critically ill in intensive care. Okay, please keep typing your questions into the chat pad or join me live on the show here and ask your questions directly to me by talking to me directly here. If there are no other questions or you just want to listen in, I'll read out the next question here from Letitia, who says, "Hi Patrick, my brother is in critical care after being stabbed in the chest. He is on a ventilator and sedated at times. He violently shakes his head and arms around. They restrained him. Why does he do that?" That's a very good question. Why is he shaking his head and arms around? They restrain him. Okay, so I've seen this many times where patients, you try to wake them up after an induced coma and they are shaking their head violently. Then you restrain them, you put restraints on them, and then it's only getting worse because, they have no recollection of what's happening. They can't talk. They're waking up. They realize there's a tube in their throat, and then it's only going from bad to worse. And it might take a while for patients to come out of that. It's not dissimilar to the question we had from Vicky a minute ago, where, her husband wasn't waking up, whereas here your brother is waking up, but he's just not waking up appropriately. Again, are they going through withdrawal? Potentially, what sedatives are being used, what opiates are being used, is there something else going on? Is there a brain injury? But you got to picture that when someone is waking up from an induced coma and they have no recollection of what's happening, why are they there, they can't ask questions, it's a big shock to the system. And when you ask survivors from ICU, some survivors say, yep, I remember everything that was happening, and others say, I have no recollection of what's happened while I was in ICU whatsoever. It's not a one-size-fits-all either. But Letitia, in your situation here, once again, we would like to look at the medical records. We would like to talk to doctors and nurses directly and, want you to listen in what questions we ask and what they say. A lot of our questioning comes down to what do they say, what's in the medical records. You can't dig deep enough. You can't go down enough rabbit holes in situations like that, So, okay. And again, what's also important in a situation like that, or even with the previous question, is to look at other organs, like is there kidney failure, for example, is there liver failure, right? Which is what can happen in intensive care. And if there's kidney failure, for example, again, they're not really excreting the sedatives and the opiates. It's too much in the system, which delays waking up, and it also delays waking up appropriately. There are patients that wake up perfectly fine. You take them off sedation and they wake up, and they recover and they move on and they know what's happened, and but it's not a one size fits all. Okay, next question from Tiffany. Oh, I'm not going into that because that's a long question. And if you have any questions in the meantime, type them into the chat pad or join me live on the show here. Here's a good one. That's come in from June, who says, I get many conflicting information from doctors and nurses. What should I do about that? Look, what may be conflicting for you is just simply not having enough insights into the world that is intensive care, or not having enough insights how hospitals and intensive care units operate in particular. You're probably talking to ICU specialists. You're probably talking to intensive care nurses. You are probably also talking to specialists. For example, if your family member went into ICU with open heart surgery, you would be talking to a cardiac surgeon. And the cardiac surgeon often looks at the heart, and that's it. The critical care team, doctors and nurses, would look at the bigger picture, right? So it really depends who you're talking to specifically. And if you are looking at conflicting information, once again, you should get a second opinion, and you should let someone look at the medical records and say, here is what's really happening, And if you've watched my videos for any length of time, you would also know that hospitals are negative by default, right? They are negative by default. And the reason for that is that, okay, let's just say they would be always optimistic and they would tell you, hey, we're doing X, Y, and Z, and then in 5 days' time, your loved one leaves intensive care alive and goes off on a, great recovery and everything will be fine. Let's just say they would promise you that and it wouldn't happen. And then you could sue them. Whereas if they tell you right from the start, oh, it's all negative, your loved one is going to die. If they do survive, they won't have any quality of life. They're managing your expectations, right? And they want to keep your expectations low, right? You don't want your expectations low. You want hope. You want solutions. But by keeping your expectations low and by keeping the narrative negative and by talking about how bad it all is and, the doom and gloom, if it's much easier for the intensive care team to then withdraw treatment, for example, because they thought, well, we told you from the start, it's not looking good, So that's one way they're using the negative to their advantage. And another thing is, let's just say your loved one isn't going to survive, and it's easy for them to tell you, well, we told you so right from the start, and that also makes it less likely for you to sue them because, they told you from the start it's not looking good. But it's critically important that you do your research from day one. Once again, when you have a loved one critically ill in intensive care, it's a once-in-a-lifetime situation that you can't afford to get wrong. You cannot afford to get that wrong. And I don't understand why, you wouldn't get help from us here, at intensivecarehotline.com, because we've helped so many families over the years to save their loved ones' lives with our consulting and advocacy, with our insights. You'd be foolish not to. If you think you can manage that by yourself, unfortunately, you will be fighting an uphill battle. We have so many families coming to us when it's too late. When they're saying, oh, my loved one's passed away now, if I had only known there was consulting and advocacy, then they want a review of the medical records wondering whether there has been medical negligence. Well, you better do the medical record review in real time, which is something we do here. Get a medical record review in real time so that you can get that second opinion in real time. You know, that is so much more timely, because time is of the essence when you have a loved one critically ill in intensive care. You can't be mucking around thinking, oh, you know, I'm sure the intensive care team will do all the right things. Well, they may or they may not. You know, the reality also is that there's a lot of good things happening in ICU. You know, I've worked in the environment long enough. There's a lot of good things happening in ICU. However, the reality also is, if you're watching this and you're coming here and you're looking for solutions, you're probably faced with an extremely challenging situation. You know, things are not going well for you and your family. That's why you're here. You know, things are going well for you and your family in ICU. Your loved one is on the mend. You know, you hopefully can focus on the positives. If our audience here is when things are not going well, I understand that, you know. So with conflicting information, coming back to your question there, June, when you get conflicting information from hospitals, you know, from hospital staff, doctors, nurses, specialists, and whatnot, get someone that's not affiliated with the hospital to give you a second opinion. And also get back to us with what that conflicting information is. It could be something very simple. You know, there might be a simple answer to it. But again, you know, some of the questions that we're getting here are very generic. All right, if you have any questions here, type them into the chat pad or get live on the show here and talk to me directly. I put the StreamYard in there. Here is an email from Peter, who says, "Hi Patrick, my dad had a cardiac arrest and no oxygen to the brain for 8 minutes. Once he got to ICU, his body was cooled for 48 hours and an MRI scan was done on his brain, where he has brain damage. He also developed seizures which are not under control. He was taken off the ventilator and has an oxygen tube in his nose. He has not answered any commands or completely waken up, as he also has pneumonia. It's been 8 days now. Is there anything as a family we should be asking the doctors and neurology doctors about getting the seizures under control, or should we still give it time?" Staying off the ventilator. You haven't. It's been 8 days now. Well, the good news here, Peter, is that he's been off the ventilator within a period of 8 days. That's fantastic. Right? That is really good. I'm surprised they've taken him off the ventilator because he hasn't obeyed commands yet or completely waken up. He also has a pneumonia, right? So the challenge here is, how are they treating the pneumonia? That's one challenge. Does he need some BiPAP, CPAP to keep expanding his lungs? Right? If he's still having seizures, what are they doing for it? Are they giving him anti-seizure medications? Right? And do they think they can get them under control? Right? What's the neurologist saying? What anti-seizure medications is he getting? Right? But it's good. The good news is he's off the ventilator, right? That is really good. And now hopefully they can focus on getting the seizures under control. Also, how often is he having the seizures? Right? They should start to mobilize him if they can. That's assuming he's hemodynamically stable. So that, you know, the quicker you can mobilize someone, that helps with pneumonia, right? Really helps with pneumonia. Now, with the seizures, getting them under control, once again, what anti-seizure medications is he getting? And what anti-seizure medications is he getting? You know, and if he's awake or if he's not awake, he can't be on midazolam or Versed for the seizures, because otherwise I think he would be too sleepy. So he must be awake to some degree, otherwise they would not have taken out the breathing tube, right? But my advice is talk to a neurologist here. Have they done a follow-up MRI scan, a follow-up CT scan? You know, really important to find out what anti-seizure medications he's on. What's the dosage? How high is the dosage? You know, that is really important for you to understand as well. Focus on the positives here. Now, I do these YouTube lives every week, usually around 10:30 a.m. Sydney, Melbourne time on a Sunday, which is 8:30 p.m. Eastern Standard Time on a Saturday night in the US, 5:30 p.m. Pacific time on a Saturday in the US. You know, usually do them around the same time, but if you're a subscriber to my YouTube channel here or a subscriber to our email newsletters at intensivecarehotline.com or intensivecareathome.com, you get notification there when I do those YouTube lives, and you get a reminder. So that will help you. Once again, if you like my videos, subscribe to my YouTube channel for regular updates. Click the like button, click the notification bell. Comment below what questions that you have. Now, we also have a membership for families of critically ill patients in intensive care at intensivecarehotline.com, and you can become a member there by clicking on the membership link or by going to intensivecaresupport.org directly. I also offer one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly, making sure you make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment, which is what you want when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time, so that you can get the second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. All of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send an email to support@intensivecarehotline.com with your questions. We also provide intensive care at home in Australia for long-term ventilated adults and children with tracheostomies, BiPAP, CPAP ventilation at home, tracheostomy care at home without ventilation. We send critical care nurses into the home. Our critical care nurses have a minimum of 2 years critical care nursing experience. So we employ hundreds of years of intensive care nursing experience in the community in Australia. We are the only service in Australia in 2024 that is actually accredited for intensive care home. We're third-party accredited to deliver that service. We also provide level 2 and level 3 NDIS support coordination. If you are an NDIS support coordinator and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for an NDIS nursing assessment, we can provide that as well. And I just want to wrap it up here. I want to thank everyone for joining me today. I do another YouTube live, like I said, same time next week. If you have any questions during the week, just type them on the YouTube channel. Send us an email. Contact us with Intensive Care at Home at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. I want to thank you once again for joining me today, and I wish you a wonderful weekend. I wish you and your families all the very best. Once again, click the like button, click the notification bell, subscribe to my YouTube channel, and I will talk to you again next week and during the week with my quick tip videos and other videos. Take care for now.